Good morning. The topic for this talk is classification of lower extremity arterial obstructive disease. And so, before we go into different classifications, the way we can look at this disease is from multiple viewpoints. These classifications evolved over time, either based on the clinical presentation, the anatomical extent of the disease, or what are the treatment options available and how do we classify this disease so that it helps in decision making for treatment. So for my talk, what I did is kind of start with how these classifications evolved over time and then look at what is their utility of these different classifications in the current era. So one of the first efforts to classify PAD was Fontaine classification, which was purely a clinical classification. It did not have any anatomical markers with it, meaning thereby there was no attempt to classify disease stenosis severity or physiological parameters. What is the tissue pressure, or what is the ankle pressure, or what is the any PVR recordings. None of those things were in there. We don't use this classification anymore, at least that's what I know. And then came what has been in the literature most often used and still has value, and I think it's a very good tool in communicating among different care providers to provide clinical extent of the obstructive PAD, and that's the Rutherford classification. It not only had clinical parameters into it, it also had objective physiological parameters, but it did not have anatomical extent of disease in its classification. Now there are two Rutherford classifications. One applies for claudicants and chronic limb-threatening ischemia, and the other one is acute limb ischemia, which is a totally different ballgame, and that's not the topic for this talk. I just put it there to let you guys know that there are two different Rutherford classifications. Then, regarding Rutherford, it is still useful. And I think when we see patient in clinical practice, we should try to put them into which category and grade they fit in, as far as their claudication distant, or if they have ischemic rest pain, or if they have a tissue loss. Then there are two classifications which I personally have not used. I'm not sure if anybody uses. One is a Bollinger classification, which describes the anatomical extent of the disease, and Graziani morphological categorization, which was unique that it provided anatomical classification in patients with diabetes and with foot ulcers and gangrene. Then came the task classification, which was initially published in 2000 and then updated in 2007. It provided anatomical variations or extent of disease, classifying into task A to task D lesions for different levels, aortoiliac, fem-pop. It did not have a below classification for any below knee disease. The idea was that these different classifications would provide a framework for different therapies for this disease process. Then we have a WIFI classification, which is a useful way of looking at how obstructive disease affects the leg. So basically it has three components, which is wound, then ischemia, and then the foot infection. And it has different grades of ulcer, different grades of ischemia, different grades of infection. Again, it did not have an underlying anatomical extent of the disease, but it did help. So the way WIFI classification is useful is it does give an estimate of amputation at 1 year and the estimated likelihood of benefit of or requirement for revascularization in different categories. Then this I found out recently while preparing for this talk. I personally have not used it, but I think this is a good classification to know. It's by American Medical Association. Now, from a holistic medical perspective, how does a lower extremity arterial or venous disease fit into the management of the patient as a whole? That's where they classify this patient into 4 categories, and they don't go into the details of extent of anatomical disease, or they are basically looking at that how bad is the disease and how badly does it affect the patient as a whole. I think this is a good way of looking at a patient as a whole for a provider, every provider, because before deciding or committing to a revascularization therapy, this provides a framework. And I can give you an example. If you have a patient with a creatinine of 3 and has a small ulcer, what are we going to gain by risking his kidneys and putting him in dialysis versus if this patient can be taken care of by a toe amputation or a transmat amputation? So how do this, just a comparative analysis of different classifications? As I said, Fontaine was the initial one, symptom-based, not used anymore. Rutherford is very useful and still should be used, or I use it. Bollinger and Ghaziani, I don't know if anybody uses. Wi-Fi is extensively used by surgeons and podiatrists because it provides a framework of limb salvage. And it also gives guidelines in terms of if revascularization therapy should be attempted. Task is again, anatomical. We still classify lesions to decide our therapy. I didn't go into details over angiosome classification. This is basically for below knee intervention work, and there are 6 different angiosomes, but I don't think we need to go into further details on this. AMA classification is looking at the patient as a whole. How does PAD of a limb fit into the overall care of the patient? Now, the more recent and the most comprehensive so far are new GLASS classification, published, I believe, in 2019 or 20, and it's from multiple endorsed by different vascular and endovascular societies as a global vascular guidelines on the management of chronic limb-threatening ischemia. So what they recommend is when you have a patient with CLTI or chronic limb-threatening ischemia, and the patient is a candidate for revascularization, it's best to obtain high-quality angiographic imaging, including ankle and foot, and then define the target artery path, that what path are you going to take to establish flow from inflow to outflow. Then, there are components to it that you grade the FemPop segment, grade the InfraPop segment, and then put it into a scoring system called overall class stage. For aortoiliac, they only give, 2 classifications, 1 and 2. But then for FemPop and infrainguinal, this is the grading system, class staging, and, that you have to apply to the patient. So, I think this is a good representation when looking at the patient as a whole. So you have anatomical complexity of the disease, which is your GLASS classification. Then how does that anatomical complexity affect the limb? That's how you look at the Wi-Fi classification. And, what risk is the patient? You can have a patient who is 45-year-old, you can have a patient who's 70-year-old, or you can have a patient who's 90-year-old nursing home patient with dementia. And that is what they are saying, that not only the anatomical complexity matters, how does it affect the limb, but how does all this fit into the patient as a unit? And then another component of looking at it is that you have to look at anatomical complexity and the limb severity. So if somebody has limb severity is low and anatomical severity is high, that's a definitive no. Again, if you have minimal symptoms, minimal tissue loss, no ulcer, then you don't need to revascularize. They kind of give a layout between endovascular versus bypass. Yellow is endovascular, open, green is bypass, and then you have some indeterminate categories, which again, you should, multiple different teams should be involved in this decision making. So as a layout, just kind of going over what they recommend. If you have a patient with the limb-threatening ischemia, stage the severity of limb threat. That is the WIFI classification. If it's a low risk and it's nothing wrong in doing wound care surveillance, and then if no improvement or deteriorates, then you need to consider for revascularization. So if we go down this path, once the WIFI fits into stage 2 or high, then the patient is the patient candidate for limb salvage. That's where that decision comes. That is this a patient who's 95-year-old nursing home patient who doesn't know what's going on? Are you going to recommend all this workup rather just do a primary amputation? So that's what they're saying, palliation wound care for primary amputation if the patient is not a candidate for limb salvage. If the patient is a candidate for limb salvage with a meaningful 1 to 2 year survival, then you go to the last staging. That's where your anatomical extent of the disease matters. And once you have this, then you make a decision that what are my revascularization options. So I think that's all I have for you guys. Thank you. Bye-bye.